ওয়ালাইকুম আসসালাম রহমতুল্লাহ বরকাতুহ। আমি এখন বড় করতে চাচ্ছি, দেখি বড় করতে পারবো ইনশাআল্লাহ।
স্যার
ফুল স্ক্রিন এই পেয়েছেন। সো আই এম হিয়ার নাও।
থ্যাংক ইউ স্যার, থ্যাংক ইউ।
আমাদের চেয়ার কি এসেছেন?
জি ম্যাডাম আছেন অলরেডি।
ডক্টর তাহমিদ।
আসসালামু আলাইকুম স্যার।
আসসালামু আলাইকুম ম্যাম, কেমন আছেন আপনি?
ভালো আছেন স্যার?
জি আলহামদুলিল্লাহ। আমার কয়েক মিনিট বাকি আছে এখনো।
স্যার
তো আমাদের জন্য কোনো যদি পরামর্শ, আপনি বলছিলেন মাসুমুল হক সাহেব, যদি কিছু বলতে চান তাহলে বলে দেন একটু, বা চেয়ার যদি আমাকে কোনো অ্যাডভাইস করতে চান, ইউ ক্যান অলওয়েজ ডু ইট।
আসলে কিভাবে অ্যারেঞ্জমেন্টটা, মানে চেয়ার কো চেয়ারের
আমি তাহলে স্যার একটু বলে দিই স্যার, এটা হয়তো আপনাদের জন্য একটু হবে। অনুষ্ঠানটা শুরু করব স্যার, আমি শুরু করে স্যার আমরা আপনাদেরকে আপনার পারমিশন নিয়ে শুরু করার পরে আমরা অনুষ্ঠানটা আপনাদের হাতে ছেড়ে দিব। চেয়ার এবং কো চেয়ার আপনারা আমাদের যারা প্রেজেন্টার থাকবেন, প্রেজেন্টারদেরকে একে একে ডেকে নিবেন, এবং আফটার দ্য সেশন প্রশ্ন উত্তরগুলো আমাদের চ্যাট বক্সে সব জমা হবে, এবং আফটার দ্য সেশন কোশ্চেন অ্যান্সার উইল বি পুট টু ইউর চ্যাট বক্স ফর দ্য কোশ্চেন অ্যান্সার সেশন। কোশ্চেন অ্যান্সার সেশন শেষ হয়ে যাবার পরে ম্যাডাম এবং স্যার আমরা আপনার কাছে আবার ফেরত আসবো, এবং আপনাকে স্যার এবং এই ইভেন্টটা সেশন সাম আপ এবং একটা থ্যাঙ্কস এবং আপনার কিছু কমেন্টস এর জন্য আপনার কাছে আবার ফেরত আসবো, এবং এরপরে আমরা সেশনটা শেষ করব। এই হচ্ছে স্যার বেসিক্যালি যে ডাইনামিক্সটা এভাবেই চলবে, এভাবেই হয়েছে আর কি স্যার।
এটা ঠিক আছে, ফুল স্ক্রিনে রাখা যাবে না তাহলে, কারণ কিছু কিছু কথাবার্তা আছে যেটা আমাকে
আটকে যাবে স্যার,
রাখতে হবে, যে আটকে যাবে, সেজন্য ফুল স্ক্রিনে আমি থাকবো না। আমি তাহলে এইভাবে আসবো এবং আমি বুঝতে পারবো। হার দিন ওরা চলে আসছে, ওদের শুনছে ওরা। আমি ওই যেভাবে মার্কিং করতে হবে বা কিছু বলতে হলে সেই যে বিষয়াদিগুলো থাকে, আমার কাছে কিছু সামারি করা আছে। সো আমি এমন ভাবে রাখবো যাতে সো দ্যাট আই ক্যান ইজিলি অ্যাপ্রোচ। আর ম্যাডাম আছেন, ম্যাডামই কন্ডাক্ট করুক। আর আমি আছি যেখানে লাগে। আমরা এখানে তো সিরিয়াল দেয়া আছে, ওরা কি সিরিয়াল অনুযায়ী আসবে? ডক্টর মাসুম
স্যার
যদি সিরিয়াল অনুযায়ী আসে তাহলে তো অসুবিধা নাই। আমি এক নাম সিরিয়াল করে লিখে নিয়েছি যাতে সহজ হয় উইথ দ্য টাইটেল। এখন একজন আছে জেরোমি রাইট, উনি কি থাকবেন নাকি অন্য কেউ থাকবে তার পরিবর্তে? তারা যদি না, ডাকাটা তো আমার পক্ষে সম্ভব বড় মুশকিল দেখতেছি আমি, কারণ তাহলে আমার কাছে তো ওই লিস্ট নাই আমার। তাহলে পুরো মানে আমি যেগুলো সব ডাউনলোড করে রেখেছি ওদের অ্যাবস্ট্রাক্ট গুলো, ওগুলো তাহলে আবার খুলতে হবে একটার পর একটা করে। ওখানে অনেকজন অথর আছে, একজন তো আর অথর না। আমি শুধু ফার্স্ট অথরকে রেখেছি যাতে আমি সহজে আইডেন্টিফাই করতে পারি। আপনার কি মনে হয় ম্যাডাম, আপনি কোথায় আছেন বলেন দেখি?
না আসলে আমার কাছে প্রিন্ট আউটও নাই, আমি আমার ইমেল থেকেই দেখতে হবে। তো আমার মনে হয় যে প্রেজেন্টার নামটা বললেই চলবে।
ইন দ্যাট কেস আমি তাহলে তাদেরকে ডেকে নিব।
আপনি সিরিয়াল করে ডাকলে আমাদের জন্য আইডেন্টিফাই
জন্য সুবিধা হয়। জি
আপনি নামটা বলে দিন যে এরপরে কে করবে, তারপরে কে করবে। এটা পারা যাবে, এটা আমাদের ভিতরে এখানে তো চ্যাট বক্সে আসলে বের করে নিতে পারবো। আবার গেলাম কোথায়?
ঠিক আছে ঠিক আছে।
আমাদের টাইম হলে তাহলে আপনি যিনি মডারেটর উনি কন্ডাক্ট করুক ম্যাডাম, আপনি কি বলেন?
জি জি, কোনো অসুবিধা নেই।
আচ্ছা জি।
আমাদের এখানে কি কেউ ফরেনার আছেন?
স্পিকারদের মধ্যে থেকে তো কেউ নেই ম্যাডাম। জেরোমি রাইটটা প্রেজেন্ট করবে দীপা বড়ুয়া, শি উইল প্রেজেন্ট দ্য পেপার। আর অডিয়েন্সের মধ্যে থেকে থাকতে পারেন ফরেনার।
ঠিক আছে, আমার মনে হয় আমরা শুরু করে দিতে পারি না, 3টা বেজে গেছে।
সো
সবাই আসছে,
drawing your attention to our host, may we start? May I start?
Yeah.
Please.
Okay.
Yeah, please go ahead.
Okay. Thank you. Assalamu alaikum, distinguished guest, learned participant, ladies and gentlemen, very good afternoon. This is Dr. Mohammad Masumul Haq, welcoming you all to this session parallel session D, non-communicable disease 1 of the annual conference 2021 of Public Health Association of Bangladesh. We are very glad and honored that we have two eminent public health professionals among us as chair and co-chair for this session. We have Professor Dr. Tahmina Shirin, Madam, Director IDCR as the chair of the session, and we have Professor Dr. Sardar Mahmood Hussain, Head, Department of Public Health, Northern University of Bangladesh, as a co-chair of this session. Assalamu alaikum and very good evening, good afternoon, and welcome, sir and madam, to this session. So, before doing further delay, with kind consent and permission of our honorable chair and co-chair, I would like to proceed further. May I, sir? May I, madam?
Yeah, please go ahead.
Thank you for your kind consent. Just before going to start the session, I'm going through the session rules in short. I hope all of you have gone through already. We have 7 oral presentations in this session. Every speaker will get 8 minutes each for their presentation. A pre-knocking will be given by the moderator at 6 minutes and a final at 8 minutes. The moderator will share and operate the slides for each presenter. Question and answer session will be held after completing all the presentation, requesting you all to put your questions to the chat box with mentioning the presenter name. I repeat, put your question to the chat box with mentioning the presenter name. And I would request all the participants of this session to please mute your mic and turn your video off for this session. So in short, these are the rules of this session, and I'm going to start the presentation. First of all, I would like to request Dr. Deepa Borua, Research Fellow, ARK Foundation, come up with her presentation, and her presentation title is Integrating Depression Care within NCD Provision in Bangladesh.
Very good afternoon, ladies and gentlemen. Assalamu alaikum. I am Dr. Deepa Borua. I'm sorry, but I'm not able to open my video. We were asked to, and I'm very sorry for this, but we were asked to open our videos during the presentation.
It's okay, please proceed.
Thank you so much. Okay, so my presentation is basically integrating depression care within the NCD provision in Bangladesh. Can we go to the next slide, please? So basically what we have been able to find through evidence is that prevalence of depression is around 2 to 3 times higher in people with an NCD, especially because they have to live with the impact of adjusting to the diagnosis, living with the pain and the social and the economic consequences that comes with an NCD. This eventually has led to the poor self-management and poor treatment adherence and poor treatment response. Bearing this in mind, ARK Foundation, along with the University of York, actually came up with an idea of trying to integrate a very short psychological intervention by the name of behavioral activation. Can we go to the next slide, please? In order to be able to integrate a small psychological intervention, we thought we actually needed to identify the answers to these 4 objectives. Firstly, how exactly is NCD care delivered right now? Second, whether NCD patients experience mental distress, and if so, how? Thirdly, how is depression care currently integrated within the NCD care? And last but not the least, what are the barriers and facilitators we would face while integrating a small psychological intervention? Next slide, please. So in order to do so, we actually conducted a qualitative interview at a primary and a secondary healthcare center in Narayanganj district within the years of 2019 to 2020. Can we go to the next slide, please? Basically, this is a view of all of the participants. We conducted in-depth interviews of 39 respondents, out of which 24 were NCD patients. While recruiting patients, we tried to manage a balance between their NCD diagnosis, and also we tried to maintain a male-female gender balance. Also, we interviewed policymakers, health facility managers, and healthcare workers. Can we go to the next slide, please? Coming down to the challenge, to the answers of the research objectives that we had set, the first objective being how is NCD care delivered, we found that pretty much it was similar across both of the centers, the primary and the secondary. It was the same, and patients were easily able to come and get the care that they wanted free of cost. There wasn't any referral system per se, and it was pretty much the same screening system. They had diagnostic tests and they were prescribed with medications. However, there were huge challenges that were identified. The NCD centers were incredibly busy and extremely crowded. There was a huge patient load, very, very long waiting times, which went about to 3 hours, and the consultation timings were just for 5 minutes. In addition to this, there was a huge strain on the medication supply. Can we go to the next slide, please? Now, What we have also been able to find through the interviews was patients did experience some sort of distress, especially 50% of the NCD patients who attended primary healthcare and 20 to 60% of patients, NCD patients who attended the secondary healthcare setting, faced some sort of symptoms of distress, symptoms such as being extremely tired, having headache, complaining of sleeplessness, having low mood and anger, and having negative thoughts and being quite pessimistic. Most of the symptoms were evident among females because they also had to think a lot about their family issues. And also a lot of these symptoms were found amongst those who had no or low education, specifically because they needed a very long time to come in terms with their NCD diagnosis. And of course, the social and economic consequences which came along with it. Can we go to the next slide, please? So once the patients have been identified by the healthcare workers, and let's just take a step back. So basically the healthcare workers were able to identify patients suffering from distress, especially through their appearances. So if there were anybody who were untidy, who would not really take good care of themselves, and who had very low treatment compliance. In those cases, the healthcare workers would pretty much be like, oh, okay, so this person could probably be suffering from some sort of depression. In this case, they had two ways to go. One, they would either prescribe them with antidepressants, or two, they would actually counsel them. Now, when we say counseling, it was pretty much consoling the patients. Or third, they would be referred to the nearest medical college which had a psychiatric department. However, the healthcare workers had immense challenges which they had to face because there was a lack of standard screening tools. Most of the health workers did not have any sort of guidance or any sort of guidance systems or training. There was no formal recording mechanism. And more so that the patient, and most importantly, patients themselves had a stigma where they were not really comfortable to speak about the mental health status with the healthcare workers. Can we go to the next slide, please? So in order to actually integrate a psychological intervention, we identified barriers and facilitators from both the patient side and the provider side. In terms of the provider side, of course, with huge workload that they had and with very short consultation times, and also the environment being not so friendly. I mean, in terms of the workspace, they found there were comments where it would have been extremely difficult to integrate any sort of psychological intervention. That being said, one of the solutions that did come up was if a separate place was allocated with separate individuals who would provide some sort of mental health counseling, that would probably work a bit better. Can we go to the next slide, please? However, the barriers on terms of the patients were comparatively much more higher. So firstly, there was the stigma which was related to depression, and especially so amongst women. They were not quite comfortable to actually come and speak about it. And they
you
also
have 2 minutes left. You have 2 minutes left. Sorry for the interruption.
No, thank you, sir. So basically, the woman would need to take permission from their husbands, or else they would have to maintain their household chores. In addition, a lot of NCD patients were quite skeptic that the support they received from their family and friends when they came to receive treatment for NCD, would that support system be evident when they'd come to receive mental health care? So that skepticism was quite evident. And especially those who had no or low education, again, they had this huge stigma, so they were not really aware about this. In terms of, and most importantly, there was the cost and the time when it came to actually travel. The facilitators, of course, the patient, according to the patients, if we were able to kind of diagnose the behavioral activation appointments in lines with their follow-up appointments, or in line with their, or coordinate them in terms of their work chores and other appointments, then probably it would be comparatively easier for them to be able to attend any of the mental health appointments that we'd come up with. Can we go to the next slide, please? Hello, can we go to the next slide, please? Thank you. So in order to conclude, and because of the time constraint, I haven't gone into a lot of details, but basically the end result is at this particular moment, if we are to integrate any sort of short psychological intervention, even that would actually need allocation of significant additional resources. It's not quite possible in this particular being at the moment. And right now, I mean, basically the government would have to allocate separate sources, especially just for mental health. And also there's a gap between the understanding of depression among patients and healthcare workers. That bridge really needs to be filled up. Can we go to the next slide, please? Can we go to, so thank you very much. With this, I conclude. So wherever you are, take care, stay safe, and thank you for your attention. Have a good day. Thank you.
Thank you very much. Thank you, Deepa Borua, for your nice presentation. And now it's time. I would like to request Shagufa Rakshanda, Center for Injury Prevention and Research, Bangladesh, CIPRB, to come up with her presentation. Her presentation title is Assessing Service Availability and Readiness to Manage Cervical Cancer in Bangladesh. Shagufa Rakshanda.
Hello, everyone. Assalamu alaikum and a very good afternoon to you all. I am Shagufa Rakshanda and I'm here to present on assessing service availability and readiness to manage cervical cancer in Bangladesh. These are my co-authors. Next slide, please. So cancer is the second leading cause of death worldwide. In 2018, 9.6 million of global deaths were due to cancer, of which approximately 70% occurred in LMICs. Next to breast cancer, cervical cancer is the second most predominant type of cancer among women in LMICs. And just like the rest of LMICs, cervical cancer is also the second most common cancer among females in Bangladesh. About 12% of females in female cancers. Next slide, please. Okay, so at the national level, the National Cervical Cancer Control Program was developed by the government of Bangladesh at all district and upazila levels. However, a study found that the nationwide screening coverage of cervical cancer is less than 10%. As such, the objective of the study is to assess the program implementation using the WHO Service Availability and Readiness tool, which is called SARA tool. It is expected that this study will note the achievements and highlight the areas which where we can further strengthen and update, where further strengthening and updating can be needed. Next slide, please. So the study design was a cross-sectional sub-study of a more extensive parent study called the SARA Survey for NCDs and Disability Service Delivery System in Bangladesh. The data was collected by 48 medical graduates who were trained on the data collection instrument and the digital software, which was used to collect the data. There are over 19,000 health facilities in Bangladesh. Of them, about 590 health facilities were included in the parent study. Of these 590 facilities, the data from only 323 health facilities were analyzed in this sub-study. Next slide, please. So the statistical analysis was done using Stata version 13. There were mainly two outcomes: service availability and service readiness for cancer services. Service availability was assessed by asking the health facilities about whether they provide any services for patients for any kind of cancer, not only specific to cervical cancer, while service readiness was calculated as a composite score. There were 4 tracer indicators which were specific for cervical cancers, which was distributed among 3 domains. The tracer indicator scores of the cervical cancer was calculated by finding the proportion of health facilities that were that had each of the 4 tracer indicators present. And then the next step was to calculate the cervical cancer specific readiness index score, which is called the CSRI score, which was determined by the mean of all the tracer indicator scores of each domain at each facility level. Finally, the mean CSRI score was calculated at each level of health facility by determining the average of the CSRI score of all the 3 domains at each health facility level. The CSRI score and the mean CSRI score was compared to a cutoff level of 70%, beyond which a health facility was considered to be ready to manage NCDs. Next slide. Thank you. There were 7 tertiary and specialized hospitals, 58 district hospitals, 60 MCWCs, 124 UHCs, and 74 NGOs and private hospitals. For the results for service availability shows that 26% of the health facilities provide cancer services. The bar chart shows the distribution as stratified by health facility level. Next slide, please. The table shows the cervical cancer specific tracer indicator scores at each level of health facilities. There were 4 tracer indicators. There were guidelines, training, speculum, and acetic acid. These were distributed in 3 domains of staff and guideline, equipment, and diagnostic facilities. Next slide, please. So this figure, the first figure shows the domain stratified CSRI scores at each level of health facility. The red line shows the cutoff value of 70%. And it's seen that only the tertiary levels were above the cutoff value. The bottom picture shows the mean CSRI score at different types of health facilities. As expected, the mean score also shows that the cutoff value for only score for only tertiary level hospital was 95.2%, which was above the cutoff value, which means that they were ready to provide cervical cancer services. But the mean scores of the other levels of health facilities were below the cutoff value. Next slide, please. So the study findings show that the health facilities in Bangladesh, except for some tertiary level hospitals, lack readiness to manage cervical cancer. Given the high prevalence of cervical cancer in Bangladesh, the management of cervical cancer needs to be more available in all health facilities of Bangladesh.
You have 2 minutes left.
Thank you. Further studies can be conducted to collect data on services for diagnosis and therapies specific for cervical cancer. Alongside this, there is a need for a well-designed plan to ensure the availability of the adequate and competent care services for cervical cancer in both public and private facilities. It may be appropriate for policymakers to develop standard operating procedures on the cervical cancer to guide the care services and achieve the set targets and contribute to the towards attaining sustainable developmental goals. With this, I would like to end my presentation. Next slide, please. Thank you, everyone. Thanks for listening to the presentation.
Thank you, Shagufar Akshanda, for your very time-demanding topic and presentation. And when WHO is looking forward in 2030 for the call of cervical cancer elimination. So thank you very much. Now I would like to request Mohammad Nur Nabi Sayem, National Heart Foundation Hospital and Research Institute, Mirpur, and his title is Estimating Model for 24 hours urinary sodium excretion from spot urine sodium and creatinine of Bangladeshi population. Mohammad Nur Nabi Sayem.
Assalamu alaikum. Thank you, moderator, for giving me chance to present my presentation titled Estimating a Model for 24-hour Urinary Sodium Excretion from Spot Urine Sodium and Creatinine of Bangladeshi Population. I am Mohammad Nur Nabi Sayem, Data Analyst of National Heart Foundation Hospital and Research Institute. Next slide, please. Background aware. The best estimate of population distribution and average level of dietary salt intake is provided by measuring 24-hour urinary sodium excretion in a representative sample. Collection of 24-hour urine is difficult for community level people. Use of the spot urine sodium concentration for estimation of dietary salt intake was proposed as an alternative to 24-hour urine collection. Next slide, please. The objective was to develop an equation to estimate population mean level of 24-hour urinary sodium excretion from spot urine sodium of Bangladeshi population. Next, please. The method was a data set which estimated salt intake from urinary sodium level by both methods such as from 24-hour urine collection and from spot urine was used. Data set contained information sodium intake of 227 participants aged 40 to 59 years selected from urban and rural population of Bangladesh. We developed formulas to estimate 24-hour urinary sodium using spot urine sodium and creatinine. Next, please. Since 24-hour urinary creatinine excretion is affected by age, weight, and height, we calculated a regression equation to estimate 24-hour urinary creatinine excretion from age, weight, and height by multiple linear regression method. The obtained following equation: predicted creatinine in milligram per day equal to minus 6.33 into age in year plus 15.06 into weight in kg plus 23.91 into height in centimeter minus 3238.45. Next slide, please. Table 1 shows the hypothesis to estimate 24-hour urinary sodium excretion. Hypothesis 1. 24-hour urinary creatinine excretion can be predicted, and the predicted value of the creatinine is almost equal to the measured 24-hour urinary creatinine. Hypothesis 2. The ratio of sodium to creatinine in the 24-hour urinary is directly proportional to the ratio of sodium to creatinine concentration in the spot urine. Next, please. We assume that if hypothesis 1 and 2 are accepted, then the proportional expression 3 will be derived from the hypothesis 1 and 2. Hypothesis 3, 24-hour urinary sodium excretion is directly proportional to the value of the ratio of sodium to creatinine in spot urine multiplied by predicted creatinine. That is XNA equal to spot urine sodium in millimole per liter divided by spot urine creatinine in milligram per liter into predicted creatinine in milligram per day. Next, please. The regression line of the estimated 24-hour urinary sodium were YNA equal to 0.78 into XNA plus 33.95. If the concentration in spot urine sodium nearly reached 0, 24-hour urinary sodium will theoretically reach almost 0, and the predicted value from the regression line will have to coincide with the measured value. Therefore, these values are transformed into logarithm, and from them we created formulas to estimate 24-hour urinary sodium excretion. This formula is expressed as the estimated 24-hour urinary sodium in millimole per day, where y prime Na equal to 1.75 into x Na to the power 0.885. Next slide, please. The scatter diagram shows the relationship between the value XNA and measured 24-hour urinary sodium. XNA in millimole per day in x-axis and measured 24-hour urinary sodium in millimole per day in y-axis. There are two curves here. One is linear curve with 95% confidence interval, and another is estimated 24-hour urinary sodium curve, which is y prime Na equal to 1.75 into xNA to the power 0.885. Next slide, please. Finally, three questions found following were obtained. Predicted creatinine in milligram per day equal to minus 6.33 into age in year plus 15.06 into weight in kg plus 23.91 into height in centimeter minus 3238.45. This equation found by multiple linear regression method. Second equation, XNA equal to spot urine Na in millimole per liter divided by spot urine creatinine in milligram per liter into predicted creatinine in milligram per day from three hypotheses. Estimated 24-hour urinary sodium in millimole per day equal to 1.75 into XNA to the power 0.885 by curve estimation. Next, please. The result was there was little difference between the estimated and measured value in sodium excretion, which was not statistically significant. The measured value of 24-hour urinary sodium were parallelly increased to every quartile divided by the estimated values 24-hour urinary sodium. There was a highly statistically significant correlation observed between the estimated and measured values of sodium. Next, please. The scatter diagram shows the analysis of agreement between measured and estimated 24-hour urinary sodium. Average of measured and estimated 24-hour urinary sodium in x-axis and difference of measured and estimated 24-hour urinary sodium in y-axis. Here,
you have 2 minutes left.
Thank you, sir. Here mean biased is 3.9, and most of the values lies between our interval values. That means minus 1.96 SD to plus 1.96 SD. Next, please. conclusions were these formulas are useful for estimating population mean level of 24-hour urinary sodium excretion. Though this method is not be suitable for estimating individual sodium excretion. For further examine the accuracy and reliability of the formulas, further studies with larger data set is required. Next, please. Acknowledge to Professor Dr. Suhail Raja Chaudhuri, Dr. Muhammad Abdullah Al Mamun, and Dr. Zubaida Akhtar for their valuable input in these studies. Next, please. Thank you. Thank you all for watching me, my present. Thank you.
Thank you. Thank you, Mohammad Nurunnabhi Sayem, for your nice presentation. Now, at this point of the session, I would like to request Taslima Khatun, National Chang Kung University, Taiwan, to come with her presentation. And her title is The Association of Nutrition and Depression Among Diabetic and Non-Diabetic People in India. Taslima Khatun. Taslima Khatun, you there?
Yeah, I am here.
Thank you. Please proceed.
Yeah. Thank you. Dear chair, co-chair, moderator, and audience, Assalamu alaikum and very good evening. I am Taslima Khatun from National Chang Kung University, PhD student. I am actually very happy and glad to here today. And thank you to the organization to organize such a nice arrangement like annual conference 2020 in Public Health Association of Bangladesh, because this time is very crucial in worldwide in pandemic situation. And I think this is the perfect time to organize such a nice presentation to sharing our research knowledge in worldwide. And this is very useful for us because though it is a pandemic situation, but still we can attend in online conference. Thank you for that. Now I am going to present one of my research topics with you, and this is on the Association of Nutrition and Depression among diabetic and non-diabetic people in India. Actually, now is the time to list your mental health in your priority. Because in this pandemic situation, now we can realize that our physical health is not only health, mental health is also very important in our physical health also, because it's also correlated with physical health. A growing evidence of support the potential use of dietary intake and intervention is an adjunctive treatment for mental health disorder. Next, please. Previous one, yeah. We saw that one of in 4 people suffer from mental health or neurological disorder worldwide, including 264 million who are suffer from depression. Depression level and poor dietary practice are independently associated with poor glycemic control in subject with type 2 diabetes. However, the relationship between them is still ambiguous. Next, please. So the objective of this study to determine the association between nutrition and symptoms of depression among diabetic and non-diabetic Indians. Next, please. This is a cross-sectional analytical study. A total subject was 510 along with 155 diabetic mellitus and subjects and 355 healthy non-diabetic mellitus subjects were studied purposely. The subject of DM and non-DM were collected from Department of Internal Medicine, State Ayurvedic Medical College of Hospital, Kolkata, and face-to-face interview was done for collection of information. Study subject were determined by 24-hour recall method. Questionnaire and food frequency intake was measured by a specific food frequency questionnaire, 30 days. Next, yeah. Quality of diet was determined using the healthy eating index score 210, and healthy eating index score comprised 12 components that sum to maximum total score of 100. Symptoms of depression were also assessed using the back depression inventory score or scale. The mean age of the respondent were 50 years. Next please. This table shows that the comparison between DM and non-DM cases of anthropometric characteristics like height, weight, body mass index, waist circumference, and hip circumference. And we see this, there was no significant association was found between DM and non-DM patients. Thank you. Next please. This figure shows that DM and non-DM people were expressing depression level, where we found that half of the DM subject were extremely depressed, and where the rest of subject were either moderate or severe depressed. At the same time, according to back depression inventory scale, we also found that 40% non-DM subject also suffered from severe depression, and significant association was also found in DM and non-DM. Next. Comparison of health eating index score and bad depression index score among diabetic and non-diabetic subjects. Here is also found that a significant association was found in healthy eating index score and depression score with diabetic and non-diabetic subjects. Next please. Comparison of healthy eating index score 2010 components and scoring standard among non-diabetic subjects and the diabetic subjects, where we found that significant association or difference was found in few dietary intakes like total vegetables, whole grains, beans, and refined grains, and others different dietary groups. There was not found any significant association between diabetic and non-diabetic subjects. In this study's conclusion, we found that diabetic depression people are living in Kolkata with low quality of dietary intake, and symptoms of depression are higher among diabetic cases, where healthy eating index score were higher among non-diabetic subjects for both issues, hereby needed comprehensive intervention. The recommendation for the study, we can recommend that ensure for balanced diet for all people, not only diabetic or non-diabetic, for all, and prevention and early treatment of different level of depression is also needed. Diabetes and depression management training should be developed in different diabetes centers.
You have 2 minutes left.
Therefore, should be given towards the implementation of depression screening, counseling, and educational program focused on depressed population, especially. We know food security is our right. That's why mental health is a priority. Your happiness is an essential, and your self-care is a necessity. That's why eat a balanced diet, and it will help to improve your mood, increase energy level, and also help you think clear and healthy. Thank you.
Thank you, Taslima Khatun, for your presentation. Now, at this point of the session, I would like to request Dr. Sharmin Sultana, National Heart Foundation Hospital and Research Institute, with her presentation, and her title is Hypertension Detection, Treatment and Control Rates in Urban Slum Population in Bangladesh. Dr. Sharmin Sultana.
Thank you. Assalamu alaikum, everyone. It's a privilege to present a very important non-communicable disease risk factor in front of this audience. I'm working as a research medical officer, National Heart Foundation of Bangladesh. Next slide, please. As you all know, non-communicable disease kill almost 41 million people each year globally, and 15 millions of people die from NCD between the age of 30 to 69 years. and 85% of this premature death occurs in low and middle income countries. Cardiovascular diseases account for most of these NCD deaths, and hypertension is a major risk factor for several common non-communicable diseases, particularly cardiovascular diseases. Next slide, please. Hypertension is also a leading risk factor for all-cause mortality and the largest contributor to global disability-adjusted life years. However, hypertension is a preventable risk factor for death and disability from cardiovascular disease. World Health Organization identified 3 major gaps in hypertension control. They reported that estimated 54% of adults with hypertension are diagnosed, and only 42% of adults with hypertension are diagnosed and treated. Approximately 1 in 5 adults with hypertension are diagnosed and have it under control. Next slide, please. The global scenario being described, I would like to mention our objective of this study was to estimate the prevalence of hypertension, its detection, treatment, and control rates among the dwellers of a selected urban slum. Next slide, please. This was a cross-sectional study, and we conducted the study in Bauniabad, a poor urban community, and the target population was between adults between 18 to 64 years of age. Next slide, please. The sample size was estimated for as 500 for 4 stratum, male, female, and the housing level 1 and 2, which was calculated based on their household wealth status. And each household was selected by simple random sampling method, and 1 individual from each household was selected by quiche method. Next slide, please. A semi-structured questionnaire was adopted from NCD STEP survey, and blood pressure was measured by Omron automatic digital sphygmomanometer. Hypertension was defined when an individual had systolic blood pressure more or equal to 140 millimeter of mercury, or diastolic blood pressure more or equal to 90 millimeter mercury, or using any antihypertensive medication. Previous slide, please. Thank you. Level of awareness was measured as a proportion of total number of hypertensive subjects that were aware of their hypertensive status. Level of treatment was measured as a proportion of subjects aware of their hypertensive status who were on pharmacological therapy. Controlled hypertension was defined as the proportion of patients taking antihypertensive medication at the time of interview and had their blood pressure controlled during the survey. Next slide, please. From this chart, we can see that the prevalence of hypertension was 19.5% among the study participants, and only 45% of them knew that they had hypertension. And among the participants who were aware about their hypertensive status, only 56% was actually on any antihypertensive treatment, and only 1/3 of them had their blood pressure controlled. Next slide, please. From this table, we can see that the participants who were aged 40 years or older had proportionately higher prevalence of hypertension, its awareness and treatment rate. However, the control rate was higher among the participants who were aged below 40 years. The female participants had proportionately higher prevalence of hypertension, awareness, treatment, and control rate. Next slide, please. From this table, we can see that the past smoker or the past smokeless tobacco user had proportionately higher prevalence of hypertension and its awareness, treatment, and control rate. Next slide, please. From this table, we can see that the BMI, the participants who had BMI more than, actually here is a typo here, that would be the cutoff value for BMI would be 25, 24.9 would be underweight and normal. I'm just making it clear for your better understanding. So the participants who had BMI more than 25 and the waist circumference about the cutoff values had higher proportion of hypertension, its awareness and treatment. However, the control rate was higher among the participants who had BMI less than 25 and low waist circumference. Similar goes for diabetes. The diabetic participants had proportionately higher hypertension and its awareness and treatment rate, but the control rate was higher among the non-diabetic patient. Next slide, please. So from this study result, we can see that the prevalence of hypertension was almost similar to the national survey report as reported by NCD STEPS Survey 2018. But we can see that a large proportion of hypertensive patients in our urban slum community are undetected, while the treatment and control rates are also very low, particularly for the male participants. The study represents a warning for cardiovascular health management in the selected community.
You have 2 minutes left.
Thank you. Next slide, please. So the scenario being described, I would like to conclude my presentation here by thanking my co-authors from National Heart Foundation of Bangladesh and Nagawa University School of Medicine, Japan, and Bangabandhu Sheikh Mujib Medical University. Thank you.
Thank you, Dr. Sharmin Sultana, for your presentation. Now, I'd like to request Sheikh Mohammad Mahbubul Subhan, National Heart Foundation Hospital and Research Institute, to come with his presentation, and his topic is trans fatty acid content in partially hydrogenated oil available in market of Dhaka city.
Thank you.
Welcome. Please proceed.
Assalamu alaikum and very good afternoon. Welcome to my presentation titled Trans Fatty Acid Contents in Partially Hydrogenated Oils Available in Markets of Dhaka City. Sheikh Mohammad Mahbubul Subhan is presenting, and here are my co-authors from the National Heart Foundation Hospital and Research Institute, Institute for Nutrition and Food Science, and the Global Health Advocacy Incubator. Thank you. We know that non-communicable diseases are the major driver of preventable cause of mortality and morbidity. And now currently it is the biggest killer, attributable for 71% death globally each year. And in Bangladesh, it accounts for 67% of all deaths. 30% people die from cardiovascular diseases. And each year, industrial trans fatty acid is estimated to cause around 5.4 lakh deaths globally. In Bangladesh, the figure is not so good. Around 6,000 people die each year in Bangladesh in relation to taking the trans fat-ridden foods. Next, please. These are the mouth-watering foods we usually take every day. And these are causing too much detrimental effect in our health. Next, please. In 2018, we started working for elimination of trans fat in line with the WHO replace package. And during a consultation with the government agencies like Bangladesh Food Safety Authority, Bangladesh Standards and Testing Institute, they always ask for the local evidence, but we all know that we are lagging behind in evidence in every sector of public health in Bangladesh. So like others, the consumption of TFA and its impact is lacking in evidence. So very little is known about the TFA content in Bangladeshi foods. In 2015, Khan with his colleagues conducted a study on the biscuits sold in Dhaka city, and they found very alarming level of TFA contents in those biscuits. However, the TFA content in Bangladesh in the Dhaka city was unknown, so that's why we conducted this study. Next, please. So our objective of the study was to generate local evidence on trans fatty acid consumption, to collect information about market chain of partially hydrogenated oil, and collection of samples available in wholesale market, retail market, and in the manufacturers. And we also wanted to analyze these samples for fatty acid profile, including trans fats. Next, please. So the methods. At first, we tried to identify the major PHO brands. And PHO brand identified from 4 wholesale and 9 retail market across the Dhaka city. We have gone through many of the market and talked to the retailer, and we came to know what are the major brands are sold. So wholesale market were selected based on the popularity, and the retail markets were randomly selected from different parts of the city. And owners and managers of the shop were interviewed. And we also know what are the PHO brands, their average weekly sales, what are the prices, and who are the main consumers of PHO. Each interviewed wholesale and retailer vendor identified the PHO brand which they sold, and those were Pusti, Pure, Shena, and the Tir. Next, please. We collected 24 samples, and 20 from the wholesale and retail market, and 4 samples we have collected visiting the 4 factory. And the sample preparation for shipment to the laboratory. Samples were prepared and stored in PET jars and labeled with a code for individual aliquots. Then we shipped those samples with a special courier pouch to Institute of Health Laboratory in Lisbon, Portugal. And the remaining samples we stored at the lab of the Institute of Nutrition and Food Science in Dhaka University for archiving. Next, please. The analysis method. Fatty acid profile was analyzed using gas chromatography, and injection temperature was 2,500 degrees centigrade at an injection gas nitrogen flow of 1 milliliter per minute. Blank and standard frame mix GLC 674 and linoleic acid methyl ester isomer mix was run at the start of the chromatogram and after every 10 samples. Next, please. This is my result, and the results are very shocking and very alarming.
You have 2 minutes left.
Thank you. The key findings are, out of 24 PHO samples, only 2 samples contain less than 2% TFA. It means the 92% of the PHO samples analyzed exceeded the TFA threshold limit recommended by WHO. The main TFA content found in the PHO sample analyzed was 11 gram per 100 gram sample, and TFA content level in the PHO sample analyzed ranged from 0.69 gram to 20.9 gram per 100 gram sample. And there were vast variation in the TFA level found within the brand. In a similar brand, we found a various level of TFA. Beyond high TFA, saturated fatty acid represent highest value in all samples with more than 50% of the total profile. So the consistency was solid in room temperature. Next, please. These are the fatty acid profile, and you can see the high saturated fatty acid and monounsaturated fatty acid, which are very detrimental to our health. Next, please. Next, please. So in conclusion, we can say that with the researcher found 92% partially hydrogenated well sample of leading brand in Dhaka city containing alarming level of TFA, more than 2% of WHO recommended limit. And as consumption of TFA is strongly associated with coronary heart disease and related mortality as well as diabetes, government should follow WHO's recommendation mandating 2% TFA limit. And to tackle the NCDs and attain SDG goal 3.4, Bangladesh should promulgate regulations, and accordingly, Bangladesh Food Safety Authority is at the verge of notification of Gazette. Next, please. Thank you. Thanks for your patience. And we want to remind daily TFA intake, not more than 2 grams per day. Thank you.
Thank you for your presentation and nice take-home message. Now time for our last presenter, Dr. Taslima Zannat, Medical Officer, Ullapara Health Complex, Sirajganj, and her title of the presentation is Medication Adherence and Health-Related Quality of Life Among hypertensive senior citizens. Dr. Taslima Jannat.
Assalamualaikum. Good evening, everyone. It's a great honor for me to participate in this conference. I am Dr. Taslima Jannat, currently working as medical officer in Ulapara Upazila Health Complex, Sirajganj. I want to share here my research result with you. My research title was Medication Adherence and Health-Related Quality of Life among Hypertensive Senior Citizens. Next slide, please. Next, please. Population aging. Please, previous slide, first slide, please. Yes, thank you. Population aging, it's a global phenomenon and also an inevitable process. Graying older can be daunting. It's not actually about graying hair, wrinkle, forgetting where she or he keep the keys or spectacles. All jokes aside, aging can bring about unique health issue. Though pandemic is going on, but we can't deny or be unmindful to NCDs. Hypertension is a quite important risk factor of non-communicable disease. Both the population aging and hypertension, both issues are major public health challenges and emerging as a burden both regionally and globally. Population projection over the world, demographic projection indicates that the number of elderly people will be 2 billion in 2020 by 2050 in the world, and in Bangladesh it will be 16.8 by 2025. So both are important issue. Hypertension, the silent killer, major cause of premature death worldwide, and I want to share here a data that 2.05% of global death among all the age due to only hypertensive heart disease in 2029, and it is high in low and middle income countries. Next slide, please. Hypertension-related complication put negative impact on individual health-related quality of life, and studies all over the world shows that poor adherence to antihypertensive medication is possible reason why success in clinical trials has not been. Sorry, everybody can hear me?
Yes, you're audible.
Oh, sorry. To maintain quality of life, the elderly hypertensive people are always advised to be adherent with medication. Next slide, please. My study objective was to assess health-related quality of life and anti-hypertensive medication adherence among hypertensive senior citizens, and to explore the relationship between health-related quality of life and anti-hypertensive medication adherence and factors associated with it. Next slide, please. My study was a cross-sectional study. Confidently, I selected 156 hypertensive elderly people from Hypertension and Research Center, Rockwood. It was interviewed in 2020 using pre-tested semi-structured questionnaire. Their health-related quality of life was assessed by Oracle 5-dimension 3-level scale, where high mean Oracle 5-dimension index value indicate better quality of life, and medication adherence was assessed by risky medication adherence 8 scale, where a high score indicates high adherence to medication and low score indicates low adherence to medicine. Next slide, please. Here my study result. I am very sorry to say that I cannot show here all my study result, though it is a learning session for me. But I am trying to show some results of my study. The mean age of all participants are 66.24. Among them, 60 to 69 years old was 70.5%, and 70 years and above was 29.5%. Maximum was male gender. It was 60.9%. It was male, and 39.1% was female. Next slide, please. Number of comorbidity along with hypertension. I want to show you slide here that 2 comorbidities among the participants was 36.50 and more than 2 comorbidities among the participants 28.20. Next slide, please. Level of medication adherence among the respondent. It was 41%, the high adherence of 41%. Study results shows the high adherence was more in male person actually. High adherence was 41.1%, medium adherence was 28.8%, and low adherence was 30.1%. The quality of life, health-related quality of life was significantly higher among the male and among those who are comparatively younger, employed, married, physically active, had income, had 2 or less comorbidities, and good adherence to medication. And medication adherence was low among female homemakers, tobacco users who take antihypertensive more than 2. Next slide, please. If I want to show my final results,
You have 2 minutes
what can I
left.
say? Thank you. If I want to keep all factors aside, the high medication adherence is the important factor, most important factor for a better quality of life. High medication adherence was responsible to increase mean index value by 0.201. Next slide, please. Next slide. I want to conclude here. Keeping all factors aside, high medication adherence is associated with a better quality of life. Next slide, please. I want to recommend here a senior citizen, especially the female older patient, would get more emphasis and prevalence. As health-related quality of life is good among high medication adherent patients, so mass awareness like on TV, radio, not only the healthcare professional, on TV, radio, Facebook, Facetune, banner, everywhere mass awareness should be improved. Necessary measures should be taken from family as well as from government to increase the economic support to hypertensive elderly people. Next slide, please. Thank you for your kind patience.
Thank you, Taslima Jannat, and thank you all of our presenters, 7 presenters. Drawing kind attention to our chair and co-chair, sir. We have another presenter. She's from Poland. She couldn't join. Basically, she was at session A, but she couldn't join there. She have already joined here. If you allow, then she can start her presentation. Drawing attention to chair and co-chair, sir.
Yeah, we can
Thank you.
hear
Thank
her
you.
presentation. Yeah.
I have
Thank
no
you.
problem. Please let her
Thank you, sir.
join.
Thank you, sir. Thank you, sir.
Thank you so much for understanding.
So welcome, Elsia. I'm not familiar with this name, so pardon me. I'm pronouncing it wrong probably. So please.
That's fine. That's fine. Everything's fine. Thank you so much. Okay, so can I start?
Yes, please, you can start.
Thank you. So my name is Alicja Forma, and I represent the Department of Psychiatry, Psychotherapy, and Early Intervention. As you have already mentioned, I'm from Poland, from Medical University of Lublin, and the topic of my presentation is highly associated with the currently ongoing situation in all over the world, and the title is the use of dietary supplements by Polish and Bengali students a way of coping with emotional distress during the COVID pandemic? Next slide, please. So basically, I want to start my presentation with some basic information because we have conducted a similar study 1 year ago, just after the outbreak of COVID pandemic. We have conducted the first survey just approximately one month after the pandemic outbreak, and we have compared our results with several countries from all over the world who have used similar psychological tools that I will tell you a little bit later. But I want to tell you that we have the main aim of our study was to assess students, specifically students' anxiety, depression, and stress levels especially during the pandemic outbreak. And as I have already mentioned, we have compared our results with several countries who have conducted similar studies, especially on students. And we have compared the results from Poland with Spain, Bangladesh, India, and China. And as you can see on this slide, on this map, D is for depression, A for anxiety, and S for stress. The highest levels of all of these variables were the highest in Bengali students. And I would like you to remember this because the results of our new study are kind of surprising for us. Next slide, please. So the objective of our study was to simply assess the relationship between the depression, anxiety, and stress level, as well as the overall emotional distress amongst Polish and Bengali students, and the relationship between the supplementation intake specifically. Because what's interesting, according to the worldwide statistics, the supplementation intake has significantly increased both in Poland, in Bangladesh, and in many other countries, which was really surprising for us. Therefore, we have decided to assess whether there is any relationship between these variables. Please, next slide. Regarding the methods, as 1 year ago, we have distributed an anonymous online cross-sectional survey amongst Polish and Bengali students that it was approximately 1 year after the pandemic duration. We have asked our respondents about obviously social demographic data, as well as questions related to one's health condition, economic situation, because we simply know that those variables might also affect emotional distress, depression, anxiety, and stress levels. We have obviously asked them about supplementation intake, and regarding the psychological tools we have used some called as depression, anxiety, and stress scale 21. This is the shorter version of the original DAS-42 scale. This one is mainly prepared for the online surveys because it's shorter, it's easier. Regarding brief cope scales, we haven't included such information here, but we just wanted to tell you that this scale was used in order to assess coping strategies of students, because since this presentation is quite short, I unfortunately haven't included such information here, but maybe during my next presentation I would do so. Okay, next slide, please. Quick results regarding the description of the study group. The groups were kind of similar both in Poland and Bangladesh because it was approximately 1,000, more than 1,000 of students. The mean age of the students was also quite similar. It was approximately 20 years old. Regarding the differences amongst the study group, the majority of respondents in Poland were women, while the majority of the respondents amongst Bengali students were men. And regarding the similarities, most of the students were medical students the first year during their university course. Most were single, living with parents. And one other difference was that in Polish students, most of the Polish students were citizens of quite larger cities, while Bengali students were mostly living in village. So it's just a brief description of the study group. Next slide, please. And regarding the results, the depression, anxiety, and stress, as I have already mentioned, during the outbreak of the pandemic, all of these variables were significantly highest in Bengali students. But as you can see, in this time, during 1 year of the pandemic duration, all of these variables are significantly higher amongst Polish students. The only similarity between those countries is that only females presented highest intensity of overall emotional distress. So both in Poland, but in Bangladesh as well. But all of these variables are significantly higher in Poland. Next slide, please. As I have already mentioned, it's really surprising because during the very first stages of the pandemic, the depression, anxiety, and stress levels were significantly higher in Bangladesh compared to other countries we were comparing in our study, the first one. But this time, this has slightly changed. Next slide, please. regarding the supplementation, it's really interesting because in Poland, as you can see, these supplements mentioned in this table were the most frequently chosen by the students. And as you can see, in Poland, they're significantly higher than amongst Bengali students. And the vitamin D, I have bolded it because it was surprising that both in Poland and in Bangladesh, it was the most frequently taken by students. Next slide, please. And regarding the differences between Polish and Bengali students, as it was already mentioned, Polish students most frequently received supplementation during the pandemic, or simply added or included supplementation during the COVID pandemic compared to Bengali students. What's interesting, the higher DAS total score, so the higher emotional distress, was observed among those students who specifically started supplementation during the pandemic, while the lowest severity of depression and anxiety symptoms was observed amongst those who did not receive any supplementation during the course of the pandemic. Next slide, please. It's maybe not associated with the supplements, but it's kind of interesting because we have also observed that the highest depression and anxiety symptoms were observed amongst those students, both in Poland as well as in Bangladesh, who did not know that they got COVID-19, which is also kind of interesting.
You have 2 minutes left. Sorry for the interruption. You have 2 minutes left.
Okay, thank you. Next slide, please. Next slide, please. Regarding the regularity of supplementation intake, we have observed that those students who were taking supplements regularly presented lower stress symptoms compared to those who were taking the supplementation irregularly, while the highest anxiety and depression were observed among those students who specifically started supplementation during the pandemic. And what's also interesting, we have observed that amongst Polish students, the lower DAS total score scores were observed among those who continued supplementation taken before the pandemic, compared to those who simply added specific supplementation during the pandemic. Next slide, please. To conclude, we have observed that lower depression, anxiety, and stress levels were specifically amongst those students, both Polish and Bengali, who simply continued supplementation taken before the pandemic. And as well, since the students who started taking supplementation during the COVID-19 pandemic presented the highest levels of anxiety, depression, and stress, we can simply conclude that it might be some kind of a coping strategy, some kind of a protective strategy of students during the pandemic. But I would like to leave you with this question in your mind, whether it was sufficient enough, because as we see that even though the supplementation intake was significantly higher amongst Polish students, they also presented the highest anxiety, depression, and stress levels. Therefore, I will leave you with this question, whether it was fine to start supplementation or not, and whether it was a good coping strategy or not. Thank you so much for the presentation.
Thank you so much. Thank you. So here are all the presentations. Now it's time for the question and answer session. I would like to request our chair and co-chair. We have very few questions here. Still, if you have any question, you can ask directly to the presenter, or you can put it in the chat box. We have a question from Fardina Omi to Nurun Nabi Saim. And her question is, as far as 6 equations are being used for sodium and potassium estimation worldwide, have you gone with reliability checking of your formulated equation? Nurun Nabi Saim, please
Yes.
unmute yourself and you can answer the question.
Yes, thank you for a valuable question. This 6 equation actually for others population of Bangladesh. For Bangladeshi population, we developed these formulas. because Bangladeshi population and foreign population level, height, weight, and immunization system is different. We use this data set. We developed formulas, and we also use another larger data set. We'll use another larger data set for reliability check. And this fixed equation apply for our data set, and measured value far difference from this equation. For that, need to develop our equation, our formulas for Bangladeshi population. Thank you.
Thank you, Nurunubis Saim. If anyone want to supplement him. Taslima Khatun, you have a question, please unmute yourself and you can ask directly to the presenter.
For a nice presentation, Alice G. You mentioned that supplement, you found your article that their supplementation and depression, there is a correlation, and especially it is in Bangladesh. I have some question to you. You mentioned the supplementation. You mentioned a few supplementation, vitamin C, D, iron, calcium, magnesium. But maybe I skip or overlook that. If you mention the dose of supplementation, how many doses they use, there is any difference between doses. And another thing, you mentioned that highest anxiety, those students are started supplementation during pandemic situation, and those are not started, higher than. I have another observation that I think those students are depressed, that student only started the supplementation. Which one first? Started supplementation and for that reason they are depressed or anxiety present, or those are depressed, they started the supplementation. Thank you.
Aliza Forma, and you have a question from Taslima Khatun.
Okay. And what's the question?
She asked directly, you missed it?
I've missed it, sorry.
Yeah,
I haven't heard that.
Yeah, again I can ask. Thank you for your nice presentation. I have actually two questions. You mentioned that you found the significant association between supplementation and anxiety. And you also shown in one table, there are a few supplements they took, like vitamin C, D, iron, magnesium, and something. But maybe you not mention the dose of supplementation they used. I think this is also a vital issue. Dose of supplementation and anxiety level. Another one thing, you mentioned that anxiety, highest anxiety was present. Those students are started supplementation during pandemic situation. Then those are not started. Actually, I think in another way, maybe those students are depressed. They started the supplementation that period. I think depression is fast or anxiety is fast. Then they started the supplementation. What is your opinion in this regard?
In my opinion, this study obviously has some limitations regarding the supplementation itself, because as we can see, we cannot clearly assess the anxiety, depression, and stress due to some of the distractions. We cannot simply assess the supplementation like. We can only say just general information, because we cannot assess whether what they answer us is correct, or whether the respondent cannot also sometimes assess their information like correctly, because they can say that they are taking some supplements regularly, but what does it mean to take supplements regularly for them? It may be for 2 weeks, it may be for 1 month. It's one of the limitations of the study, and I'm sure that it's some kind biased, due to this, it's hard to assess, honestly.
Yeah. I think dose and duration of supplementation also a very big issue, the correlation of depression and anxiety, right?
Can I add a little?
And there was another one question. Sorry.
Taslima.
Yeah.
Can I add a little?
Yeah. Sorry. I also another question asked you. That means supplementation and depression. Which one was first? Those people are depressed, they are started the supplementation, or those are use the supplementation, they are depressed? What is your opinion?
Could you repeat, because I have heard it very in.
So she asked that what was the first supplementation or first depression?
Yeah. What was first? Supplementation or what?
And depression, which developed? Depression developed before supplementation, or supplementation gave after depression?
Okay, so it's as I have already mentioned, it's another. Thank you. It's another limitation, because we cannot simply assess as well what was first, because we were assessing the scale in the severity of specific symptoms at this very moment. We were not assessing the students previously, so we cannot say that the students had depression previously. We cannot assess whether they had anxiety previously. We're just assessing the particular specific time. And we cannot simply say that, because maybe they had depressive symptoms previously.
Yeah.
Maybe they were they presented anxiety or stress symptoms as well, because everyone, even here, we have some symptoms of depression, anxiety, or any other symptoms associated with emotional distress. We simply cannot assess this. Maybe that supplementation was, as I have mentioned, maybe it was some kind of a coping strategy. We cannot even assess that, but as we can simply conclude from the results. It's also one of the limitations of our study. We have already published one publication in one of the journals, and we have also used similar tools. And we have also mentioned this one as one major limitation that we cannot simply control, because, as you know, it's the questionnaire, online questionnaire. We didn't have like controlled group of people. It was just only an online survey. So we're aware of this limitation and simply cannot assess this.
I think you were also another limitation. You are not considered the other confounder, like which are related to anxiety or depression.
That's true.
I want to interfere.
Yes.
I want to interfere. Please let me speak a little. Yes, sir. Please go ahead. Actually, with the outbreak of pandemic, COVID-19, there was a widespread fear factor throughout the whole world. So people could have been stricken with anxiety, depression, etc., and many things. And definitely the drugs, it is not, these are the vitamins and minerals, as Alicia told, added. And it has increased definitely a little bit of immunity, but it has increased the confidence in my judgment. So it cannot be, Alicia Farma is very much honest in her opinion that it was not excluded or included.
Yes.
It was just online survey. So much of discussion on this will waste your time. Do you know about placebo, Taslima?
Yes, sir.
Have you ever heard about placebo?
Yes, yes. Why
yes.
not? Yeah.
So that also acts as a placebo as well. Alicia, do you know what is placebo? Sometimes you give something and you feel that you are taking some drugs and it will give you remedy and you feel comfortable. So you are quiet and cool. That is what is a placebo. So I think much of discussion is not needed over here, and it will only increase the duration and time will pass and other question answer session can be interrupted.
Thank you, sir. Thank you. Still, we don't have any other question. So with your
Masum, I want to
sir,
put 1 minute.
Taslima had a question. Taslima had a question.
Sir,
After
Professor,
the question and answer session.
Sure, sir. Sure.
Should I speak or somebody else is speaking?
Sir, you had a question to Taslima. I saw.
Yeah.
Please
Yes.
that question.
Yes.
In your study, we found that non-diabetic patient in India had more depression than diabetic patient.
No, no, sir. No, sir.
Then
Diabetic
what-
patient are more depressed than non-diabetic.
Have you seen a result? Maybe I was wrong. I was saying on right and left side. So if it is so, why do you think that they are depressed? For their diet or for other reasons?
Diet and other reasons also. We know if
Explain.
any person. Yes, sir. But it is very common that we know that if there is anyone suffering from endocrinology problem like metabolism disorder like diabetes, they also parallelly have developed some complication like retinopathy, like kidney disease, like heart disease, like gangrene, severe complication, some and also parallelly develop different type of complication. And we also know that diabetes management, like manage the insulin, is also a big issue for lower class people. So this is a big issue to management of treatment also. And that's why sometimes they also unable to manage by themselves or self-care. They are also another issue, I think, so manage. Those people are food lover. I think they are very weak in different type of foods, mouth-watering food. Doctors and dietitian also suggest that diabetic person, some foods you have to moderate, some foods you have to avoid. It's also some people not taking positively. It's also some people take depressed. Oh, I have to control myself. It is my favorite food. I have, but there is lots of facility, but there is no chance to eat. There is lots of reason for depression.
So
And
I
that
have
also
also-
is one reason.
Okay.
So I have also a question to you, Taslima Khatun.
Yes, thank you.
That you are here, you have mentioned that there is more depression among the diabetic patient. Did you stratify these people who are having complicated diabetes with complications like that you have already mentioned? Retinopathy
Yeah.
So I mean,
there was, in my presentation, I have only very few slides present here because there is no scope, only 8 minutes there. I also found different type of complication like diabetes related complication like heart disease plus eye problem and others complication also they have.
And did you find any association between these complication and depression?
We only saw actually comparison between dietary intake and depression.
Then confounding factors remain there.
That's why we found that those people are food insecure and that groups are more chance to develop the depression, moderate, severe and extreme level.
Okay, ma'am, Taminda ma'am, possibly have got the answer. It is also not a complete one. The gap always remains in a studies, and that will continue to remain. So there is that no complete package is available here. No problem.
Of course.
Anyway, thank you.
Thank you. Just
what is our next portion?
Before concluding our question and answer session, Professor Dr. Shamoni Hussain sir wanted to say something. I would like to request sir to say something.
Thank you very much. Actually, I'm not talking on these subjects. As an organizer, I just want to thank the chair and co-chair and all the participants and all the speakers for these wonderful sessions. And I know Professor Tamina Shirin is very busy with these COVID situations, but she has given the time. Thank you very much, Tamina. It is my privilege that she is my direct student, but still it is very good that she is here. And of course, the Professor Sardar Mahmood Hussain, and he's a very senior public health expert in this country and leading the Northern University of Bangladesh. So thank you very much for your participation. And of course, all the presenters who are here, the presentation was wonderful. I was really very carefully listening to all the presentations, and all the presentations very good. So that's just to say thanks, and finally to the moderator also. So thank you very much. Let me hear from the co-chair and chair. Thank you all. Thank you.
Thank you, sir. Now I am just going to hand over the session to our chair, Professor Dr. Tamina Shirin, madam, to sum up the session.
Okay, thank you. Thank you for inviting me in this forum. Actually, first of all, I would like to thank all the presenters for their nice and informative presentation on these NCDs. Actually, we all know that NCD is a very, major public health concern, not only for the Bangladesh, for all over the world. If we think about the food habit that we are having now, and another thing is that, if we look at our health facilities in Bangladesh, the structure is good. We have the Upazila Health Complex, community clinics, then secondary and tertiary level healthcare facilities. But even then, though we have this type of health care facilities in Bangladesh, but so far I feel that there is lack of coordination. The communicable, not the non-communicable diseases or NCD, it remain in the rural area, in the urban area, urban slum. The poor and rich people all are having this sort of NCD. So in that case, if we have a good communication from the tertiary level hospital down to Upazila level hospital or the community clinic, so we can just refer these NCD patient from the rural area to urban area. Another thing is that the most unattended area part is the urban slum area. And then they don't, they can't even feel that they are having the diabetes or they are having hypertension. So they don't, actually we got this reflection in one of the presenters. So in that case, if we have a very good structure addressing those sort of NCDs, that would be good for future. And we have NCD program in DGHS, and we have operational budget, OPs there with the budget. So we can actually address those areas. But the thing is that we need the coordination. Another thing is that we are having so many evidence. We have a huge amount of data, and today also we have found some sort of evidence from their research, but these are all scattered. I think that the data that we have now, or the evidence that we got from this presentation, today's presentation, or there are another presentation in next on 4th September. So from those things, can we actually just translate this data to action, or make some evidence that we can put it in front of the policymaker, so that we can make a change in our system? That will be the implication of this research, because we are doing research, we are publishing the paper in different peer-reviewed journal, and it will add value in our career. But for the if we think at national level, we have to translate those data into action or into policy, and to disseminate those things in front of the policymaker. In front of, it should be disseminated among all the stakeholders. It can be interministerial, because a lot other ministries are also related to change this sort of situation. So, actually, from this presentation, if we keep it like this, we will not get any type of outcome. So we have to think about the implication. This is one thing. Another thing is that now we are going through the pandemic situation, the COVID-19, and we know that this COVID, the SARS-CoV-2 infection also affecting different organs. We never know what will happen in next few years. We will be able to know what is going on. We also found that the person who is infected with this SARS-CoV-2, though they are not, they were not diabetic before, but after the infection, they are having this diabetes. They are taking insulin for a long time, and sometimes some of them they didn't get rid of it. And the diabetic patient, they are having more blood sugar level, and it persists for long. And these COVID or SARS-CoV-2 also affecting liver, obviously lungs and kidney also. So in that case, the we might have chronic patient later on. And during this pandemic, this NCD remained unattended. This is another, problem that we may face it later on. So with these few words, I would like to stop here. Thank you.
Thank you, madam. Thank you for your discussion. Now, I'd like to register co-chair, sir, to say something regarding the session.
Assalamu alaikum, everybody. Good afternoon. I think it's a very brilliant session, and the presentation was absolutely appreciable and fabulous. Every participant put their best to present, particularly the person who joined lastly, Alicia Forma. I also see her eagerness to join a public health conference like this and put a little bit to the forum, so that people can know and the difficulties and people come forward. So it is always encouraging, and public health people always came forward to contribute. And non-communicable disease, it's a real global burden. It is giving us a real global burden. We know even in Bangladesh and globally. If I say 7.1 billion cases of diabetes in Bangladesh, it was in 2015, it can go further up. If you make a survey now, we can go up. So not, if we limit to ourselves to non-communicable disease only, we have to put our best to control it. It is more than 50%. And this is a chronic process. This continues. It affects the heart. We deal with cancer and everything. So what we need to do, put our best, and constructive research work should be done, and the output should be translated into action, so that we can forward it to the government, and government can convert it into action, as chairman madam told. So we should take care of this, and I'm thankful to the organizers, Shah Munir sir particularly, who is the chairman of the Public Health Foundation, and his team for organizing this excellent first time conference, and so that people can come forward and contribute, and further research continue. We shall do it in future also, and we will be happy to be a party to it, always, all the time, because without public health, we cannot control anything. Without contribution of the public health, not communicable, neither communicable nor non-communicable disease can be controlled. So where there are disease, there will be public health. And thank you, Munir sir, and all other participants for your kind participation and contribution. Assalamu alaikum warahmatullah.
Walaikum assalam. Thank you, sir. Thank you for your speech. At the beginning of the session, I requested all of the participants to turn off your camera, but now I am requesting all of you to turn on your camera. We need to take a photo shot for the official.
Sorry, I cannot open my camera.
Okay.
Now
No
it's
issue.
okay.
It's okay, Deepa Purva. You told me. So
It's stopped by host, yeah.
So,
I don't know what's the problem.
I'm sorry, the person name.
it's okay. So I'm taking the snap here.
Yeah, now it's okay.
Thank you.
Thank you.
Another one.
I cannot open my camera because host.
No issue. So thank you. We have come to the end of the session. We have come to the end of the session, and thanks to all the speakers, participants, honorable chair and co-chair of the session. And thanks from my part also to the organizer to giving me the chance for moderating this session. Our next session will resume on tomorrow, 4th September at 10 a.m. with plenary session 2. Hope to see you there. Till then, goodbye. Allah Hafiz. Assalamu alaikum.
Assalamu alaikum. Thank you.
Assalamu alaikum. Bye.
Assalamu alaikum. Thank you. Assalamu alaikum.
So much. Goodbye.
Night. Mithila, congratulations. Thank you, sir. Thank you, sir.
Thank you, sir. Assalamu alaikum.
Thank you, Taslima. Masoom,
Thank you, sir.
Good job, Masoom.
Thank you, sir.
Thank you, everybody.
Thank you all.
Allah Hafiz.
So